My name is Stephanie Pollard. My advisor was Dr. Kelly Gibson, and today I will be talking to you about my research, the impact of psychiatric care in pregnant women with opiate use disorder using a propensity score analysis. We know that the incidence of opiate use disorder in pregnant women has more than quadrupled in the last 20 years. We have also seen a concomitant rise in neonatal opiate withdrawal syndrome, or NOWS. NOWS is characterized by a constellation of symptoms including irritability, restlessness, difficulty feeding, nausea, vomiting, seizures, tremors, and overall autonomic system irritability and dysregulation. And included in this picture is that 2/3 of pregnant women with opiate use disorder have coexisting psychiatric disease. However, it's very difficult to do research that examines the interplay of mental health on maternal and infant outcomes because there are so many variables at play. Likewise, women with opiate use disorder are highly likely to use other substances, but few studies include mothers with polysubstance exposure. The incidence of NOWS is variable, with estimates ranging from 50 to 80%, meaning that the likelihood that a baby exposed to opiates will go on to develop withdrawal is as predictable as the flip of a coin. One model that looks at not just the direct effects of opiates in utero, but the constellation of stressors that may contribute is proposed by Conrad et al. In a recent paper. And this shows that there may be stressors that the neonate is exposed to in utero that exert programming effects on the developing fetus. These include maternal psychiatric disease, history of trauma, something called maternal emotional dysregulation, which refers to a vulnerability for psychiatric disease, including substance use disorders. It's a lack of an awareness, acceptance of emotion, an inability to control behaviors when faced with distress. The current theory is that because mom has an inappropriate response to stressors or a increased alertness and stress in the face of these stressors, that baby then also has inappropriate stress responses and develops influences, and this may influence the fetal hypothalamic pituitary adrenal axis, the HPA axis, and this may lead to increased incidence of withdrawal in newborns. Propensity score analysis is a tool that can be used when it is difficult, unethical, or impossible to construct a randomized trial to assess your outcomes of interest. And what this allows us to do is draw causal inference from observational data. The way this works is that you take a population with varying characteristics, such as our moms with opiate use disorder, with polysubstance use, psychosocial stressors, all of these factors, and you match these individuals treatment and control on a one-to-one basis. And similar to a randomized control trial, by balancing these additional variables, you kind of cancel them out in the same way randomization would cancel out the differences between groups. And once you create this propensity score, this propensity to receive treatment and match the individuals, you're then able to do some checks to make sure that your model is balanced and that there is minimal difference between the groups. And finally, then you can perform a difference in differences estimates that will allow you to make causal inferences on your treatment to the outcome of interest. So we decided to use a propensity score model, specifically a matched pairs analysis, as I just described, using data from our mother and child dependency program. This is a prospectively collected data set, and we wanted to examine the impact specifically of psychiatric care on the incidence of neonatal opiate withdrawal syndrome in newborns and the severity of neonatal opiate withdrawal in terms of days in the NICU. We included all women that gave birth after 36 weeks gestational age in our data, in our mom's data set. We didn't we wanted to minimize confounding based on prematurity, and that's why we chose to include those just at 36 weeks gestational age and beyond. All of these women have a history or current opiate use disorder. Some are on methadone, some are on buprenorphine, and some may not be on any medication-assisted therapies. So we matched these women-infant dyads on factors that predispose women to receive psychiatric care and predispose infants to the developing nows. And this is how we constructed our propensity score. The maternal factors included demographic, socioeconomic status, smoking status, degree of substance use, presence of psychosocial stressors such as polysubstance abuse, unstable housing, insurance status, history of prostitution, lack of custody of children, history of incarceration, or history of physical assault or rape. Infant factors included characteristics known through the literature to influence incidence of neonatal withdrawal, including male sex, breastfeeding, and small for gestational age infants. And so to perform our propensity score analysis, we use something called nearest neighbor matching. So we generated a propensity score, which is a probability that a patient would receive psychiatric care, which was our treatment, based on those factors that we just discussed. And using that propensity score, we matched groups, one treatment to one control, and with a matching algorithm using a standard caliper as documented in statistical literature. Once we had our propensity scores and matched our data, we then checked and validated our model, specifically looking at standard differences between those variables that we included in the model, ensuring that there was a less than 0.2 standard difference between treatment and control groups. This indicates a good balance between treatment and control on the variables that we included in the model, and that there was less than a 50% non-overlap in distributions between the treated and control groups. You can see the results before matching. These were all of the variables that we included, and you can see the incidence in treated and control groups and the standard differences here. There are quite a few that are above 0.2 in this data before our matching, including in psychiatric diagnosis, polysubstance use, and neonatal characteristics. After matching, you can see that the standard difference between groups for all variables included in the model is less than 0.2, indicating a good balance between the treated and control groups. And so for our results, 645 women infant dyads were included in the model. These were women with opiate use disorder who had deliveries after 36 weeks gestational age between the years 2000 and 2019. Of those 645 women, 418 or 64% had a diagnosis of prior psychiatric disease, which is consistent with the literature indicating a high prevalence of concurrent psychiatric disease. As noted in the previous slide, our groups were well matched using nearest neighbor matching. In our differences estimates, neonatal opiate withdrawal syndrome was less likely in infants delivered to moms who received any psychiatric care in pregnancy, with a relative risk of 0.10, which is quite low. However, in infants with neonatal opiate withdrawal, there was no difference in the severity of withdrawal as indicated by the length of NICU stay if mom had any psychiatric care. The results of this study support that psychiatric disease is highly prevalent among pregnant women with opiate use disorder. It also found that psychiatric care, in addition to medication-assisted therapies, may reduce the risk of neonatal opiate withdrawal syndrome. And programs for women with opiate use disorder should include treatment for coexisting mental health disorders. The strengths of this study include the utilization of a large data set with women with opiate use disorder, polysubstance use, that has a robust set of variables that were measured spanning nearly a decade, and the use of propensity score analysis in order to measure our outcome of interest. There were some limitations. This was a secondary analysis of a prospectively collected data set, and there were some variables that were not included and measured, including exposures to SSRIs, other psychotropic medications that may play a role in withdrawal and could be included in future studies. I have nothing to disclose in terms of conflicts of interest. These are my references. Thank you very much for your time.